Good morning. Thank you for joining us for the annual Crohn's and Colitis Foundation Georgia Chapter Patient Education Program, What Every Patient Needs to Know. My name is Mary Esna Shari. I'm the Director of Education for the Crohn's and Colitis Foundation, and I'd like to thank you for signing up today and joining us. The Crohn's and Colitis Foundation's mission is to cure Crohn's disease and ulcerative colitis and to improve the quality of life of children and adults affected by these diseases. Just some minor housekeeping. Please remain on mute during the presentations. You have a few options for submitting questions. You can submit questions that everyone will see in the chat box. You can also send me, Mary Esna Ashari, a private message via the chat box if you don't want the entire crowd to see it. And if you have a private question you wish to be asked but remain anonymous, you can email it to me at the email address you see on the screen. I'll also put my email address in the chat box. This program is being recorded and the link will be sent out next week and posted on our website. We do have so many patient education support and advocacy resources on our website, and you can see local programs and events that are happening in the Georgia chapter on our website as well. I am your National Education Director based in Atlanta, and if you need any assistance with anything, please feel free to contact me. We also have our IBD Help Center, which can be translated in up to 30 different languages, and they are a wealth of knowledge and staffed by master's level social workers. Thank you so much to our sponsors, Atlanta Gastroenterology Associates, UCB, and Janssen Pharmaceutical Company of Johnson & Johnson. I'd like to introduce our three speakers for today. Dr. Doug Wolf is a gastroenterologist at Atlanta Gastroenterology Associates here in Atlanta. He is the co-medical director for the Southeastern Center for Crohn's and Colitis, and he is a longtime dedicated volunteer of the Crohn's and Colitis Foundation, member of the Georgia Chapter Board, our Chapter Medical Advisory Committee, a participant in our Team Challenge Half Marathon fundraising program. He volunteers as a Camp Oasis physician, and he's also a member of the Foundation's National Scientific Advisory Committee. Today, he'll be presenting information on extraintestinal manifestations in IBD. Our second speaker for the day is Dr. Heba Iskandar. She joined Emory Healthcare in 2010 and is the Director of IBD Clinical Research, and she's also an assistant professor at Emory Healthcare. She too is a dedicated volunteer of the Crohn's and Colitis Foundation and serves on the Chapter Medical Advisory Committee and our National Scientific Advisory Committee. She will be presenting information today on pain and fatigue in IBD. And our third speaker today is Dr. Tanvi Dare. She joined Emory Healthcare in 2009 and is the director of the IBD Center. She's an associate professor at Emory and also a dedicated volunteer of the Crohn's and Colitis Foundation. She is a member of the Chapter Medical Advisory Committee and the National Scientific Advisory Committee, and she will be moderating our question and answer session today. So with that, I will stop sharing my screen. And I will turn it over to Dr. Wolf. Dr. Wolf, you can now share your screen and we will present on extraintestinal manifestations.
All right, well, I know there's a big silence. Let's see, okay, we're there. I hope everyone can see. Someone, Mary, call me or shout out if you can.
Everything looks great.
That's great, okay, thanks. So it's a pleasure to be with you today. I know we're not in the same room, but this is the safer way to have our program today, and I've been part of a number of web or Zoom meetings, and I think they work amazingly well. And Mary gave you some guidance as far as how you can communicate with us during the program if you have questions or whatever. And then this will be taped, so you can just relax and enjoy. No need to take any notes or whatever. Today, I'm going to be talking about extraintestinal manifestations of inflammatory bowel disease. And you may or may not know what these are, and it doesn't matter. I hope to share that with you today. But the bottom line is that, Crohn's disease and ulcerative colitis are conditions of intestinal inflammation and ulceration. And so the extraintestinal manifestations are abnormalities of other tissues in the body that are inflamed, and this is driven by the inflammation that occurs in the intestine. So that's why they're termed extraintestinal. And so I'm going to give you a couple examples of intestinal inflammation. Many of you have had colonoscopies, but few of you have probably viewed a colonoscopy. This is the white things that you see here, those are ulcers. And the red is inflammation, the angry inflammation, and a lot of the inflammation and ulceration occur together. And there's a huge pseudopolyp, which is just a reaction to inflammation. And there's a big white ulcer in the 9 to 12 o'clock portion of the distal left colon. So, this is severe inflammation and ulceration of the left colon. And this is what drives the extraintestinal manifestations, which occur in about 50% of patients with IBD. Now, let me just show you another endoscopic photo. And that little prong at the bottom is a biopsy forceps. I'll tell you, that's of course to take tissue samples, which we often do during a colonoscopy. But this is really just a short video to show you examples of other ulcers. Here, there's dozens of small ulcers. These have depth, but they're very small. These forceps are about 7 millimeters in diameter. And so you see some of these ulcers are just maybe 3 millimeters, 5 millimeters. They're small, but they're deep. And they're penetrating the tissues of the intestine. They don't penetrate through in this patient, but they can in others, and that's what leads to fistula and other complications. But it's these ulcers that, again, drive the inflammation of these extraintestinal manifestations. So these 5 manifestations here are some of the classic extraintestinal manifestations of Crohn's disease and ulcerative colitis. And they include oral or mouth abnormalities, joint abnormalities, skin abnormalities, eye abnormalities, and then something doctors term hepatobiliary, and another term would be liver and gallbladder abnormalities. So some of these abnormalities parallel the activity of the Crohn's disease or ulcerative colitis. And so the more active the IBD is, the more active will be the peripheral arthropathy, which is joint aches, some of the larger peripheral joints, the skin abnormalities, one termed erythema nodosum, and then some eye redness, which is episcleritis. And then some of these abnormalities are present. They're associated in patients with Crohn's disease and ulcerative colitis, but their activity is independent of the activity of the Crohn's disease or ulcerative colitis. And these include the small joint disease of the hands and feet, the back disease, sacroiliitis, and ankylosing spondylitis, we term axial arthropathy. That is takes an independent course to the activity of the inflammation. Pyoderma gangrenosum, a skin abnormality, uveitis, which is an eye abnormality, and primary sclerosing cholangitis, which is a liver or biliary abnormality. And so there are a host of things that we're going to talk more about. So let's talk about oral Crohn's disease or mouth abnormalities. And the most common manifestations are aphthous ulcers, also known as canker sores. Okay, and aphthous ulcers occur in, I mean, they're more common in patients who don't have IBD. So they can be due to viruses that we can or can't identify. They can just be to other nonspecific causes that we have not all characterized, but they are a classic feature of Crohn's disease and ulcerative colitis. And I'll show you an image of one of them shortly. And sometimes this ulceration in the mouth, in the inside of the mouth, can extend to the jaw and the lips. This is much rarer, but you can get lip swelling that I've seen on multiple occasions, and that is termed cheilitis granulomatosa. It's a more severe form of these mouth ulcers, and you can even get an irregularity of the tissues in the mouth called cobblestoning and swelling and inflammation of the gums. So here is an ulcer, and okay, let's go back. Can you see my pointer or not?
Yes, we can see your pointer.
Okay, great. So that's the ulcer, that depth there. That is an ulcer, kind of a hole, a depression in the tissues in the mouth that is due to Crohn's disease in this case. So oral and aphthous ulcers such as these, they often have a white base. This one's more tissue colored. They can predate the diagnosis of inflammatory bowel disease. They are more common in Crohn's than ulcerative colitis. As you can see, 10 versus 4%. And oral ulcers, of course, can be a sign of the underlying IBD. So if you get these, and I may mention this again, if you have other features that might be due to inflammation or some abnormality you're not sure of, ask your doctor about it. Say you wonder if it might be related to IBD, and some of these things are, and we'll talk about more of them. So now let's touch base on the arthropathy, and that's just a fancy term for joint pain or joint disease. This occurs in 20 to 40% of IBD patients. It's inflammatory in nature and causes symptoms such as morning stiffness, nighttime symptoms, and it often improves with joint use. So, as we get older, we also get morning stiffness and symptoms that improve with joint use. So sometimes it can be hard to sort out, but again, these arthropathies are not exclusive to inflammatory bowel disease, but in a patient with Crohn's disease and ulcerative colitis, they certainly can be driven by that intestinal inflammation. Okay, so they do occur in the knee and peripheral joints, and then known as type 1, and those are closely linked to underlying bowel disease, inflammatory activity, and they may manifest before gut symptoms. And this is especially true in kids where joint aches or extraintestinal manifestations often precede clear-cut intestinal IBD and can be a clue to the diagnosis. And then there are the small joints, type 2 peripheral arthropathy, that are not related to bowel activity. And importantly and gladly, these changes, this peripheral arthropathy typically does not cause any joint deformity, which is very classic in rheumatoid arthritis. So this is distinct from rheumatoid arthritis in that it causes joint pain, joint abnormalities, but no damage to the joint. This slide depicts something called ankylosing spondylitis and sacroiliitis, which occurs at the junction of the sacrum and the iliac wing. This is the pelvic bone. And so this is the core of low back pain that may be due to inflammation. This is the low back, again, the pelvis. And this not infrequently occurs with inflammatory bowel disease. So it is an inflammation of the spine, occurs more in males than females. It causes lower back pain, can cause stiffness, can cause buttock stiffness, which again improves with motion. And this type of inflammatory bowel disease, back disease, is unrelated to the underlying bowel activity. Again, it occurs or co-occurs with Crohn's and UC, but doesn't parallel the activity of those diseases. And there is a potential for joint destruction, and there are treatments ranging from physical therapy to biologics, such as the anti-TNFs. And so here, treatment of these joint manifestations, NSAIDs, can be effective, so even aspirin or ibuprofen, but their use, as many of you know, is controversial because in some patients, and maybe it's half of patients, they might get flares of their IBD if they take NSAIDs. So whether or not to use that kind of medicine needs to be addressed with your doctor. Sulfasalazine is another alternative. It's a prescription medicine. It's actually the prodrug for a lot of the mesalamine products that are the cornerstone of ulcerative colitis therapy and sometimes used in Crohn's. But sulfasalazine is different from many of these 5-ASAs in that it is metabolized and splits into a 5-ASA, which works for the bowels or intestines. And then the other half of it is sulfapyridine, which is unique to this sulfasalazine, and that controls inflammation in the joints. So sulfasalazine can be a valuable agent for joint inflammation and discomfort. Methotrexate is the immunomodulator of choice for joint inflammation. As I just mentioned, anti-TNFs are frequently effective for some of these situations, especially those with ankylosing spondylitis or similar back disorders. And these issues are often very complicated, and if one has significant symptoms, a team approach utilizing or working with a rheumatologist and perhaps physical therapy is often beneficial. Eye manifestations can occur in 4 to 10% of IBD patients. And this is an example of episcleritis, which occurs in about 2 to 5% of IBD patients. Again, 2% in one study, 5% in another. And what it is a very, very superficial, mild redness of the sclera, the whites of the eyes. And you can see that here, certainly in this pattern. And you know, you can see this with conjunctivitis, with a viral thing, with nonspecific eye irritation, or this can be associated with Crohn's disease or ulcerative colitis. This episcleritis is a very mild eye manifestation typically, and does occur in parallel with the IBD disease activity. It typically does not impair vision or cause long-term complications and can be treated by treating the underlying IBD or sometimes using corticosteroid eye drops in conjunction with an ophthalmologist, an eye MD specialist. Uveitis is a more advanced, a more severe eye manifestation and occurs in a smaller percentage of IBD patients, 0.5 to 3%. The symptoms are pain, redness, and there can be visual loss, but it may be painless. It's 4 times more common in women than men and does not correlate with the IBD activity. So the GI symptoms may be inactive, but the uveitis may be present and leading to complications. And it's so important if there's any eye manifestation that be clarified and evaluated by a specialized eye MD, an ophthalmologist with experience in these conditions, because delayed diagnosis, or more appropriately, delayed management, can lead to complications such as glaucoma and even blindness. And This is just a depiction on the left of the inflammation of the eye that you see in uveitis. And this is one way, just with visualization by an examiner and an abnormal pupillary area, but an eye specialist, an MD, uses something called a slit lamp. So an ophthalmologist uses a specialized eye instrument and can see things in much greater clarity than we can with the naked eye. So it's so important that an ophthalmologist be involved in the evaluation of any eye abnormality to be sure there is not a more severe condition going on. Scleritis is another eye inflammation, which is redness or inflammation of the whites of the eyes. And it can cause eye pain, can cause abnormalities of structures around the eye, and often has symptoms of pain that worsen with eye movement. It's relatively rare that it can occur, and it can threaten one's vision, and again is not associated with the activity of the intestinal disease. There are also dermatologic manifestations or skin manifestations of IBD, and there are a whole host of them, and I'm just mentioning 3 of the more classic ones that are associated: erythema nodosum, pyoderma gangrenosum, and psoriasis. Erythema nodosum is more common than pyoderma and occurs in 3 to 15% of IBD patients. These are raised, tender, pink to red nodules, classically occur on the shins, typically on the front or anterior, also termed the extensor surfaces, most common on the lower leg, and does parallel IBD activity. And so it can be managed by treating the underlying IBD with the appropriate medications, and typically resolves spontaneously with appropriate treatment and doesn't require anything specific. These are examples of erythema nodosum with red nodules on the lower leg. And these are painful nodules that you can feel if you touch them. And they may be small as seen on the left leg there, or they may be fairly large as seen on the right leg. Often multiple, but maybe single. And sometimes it's hard to be sure if there's just one, whether it's a bruise and what it is. And again, a dermatologist can help clarify and sort that out. Pyoderma gangrenosum is a rare skin manifestation occurring in 0.5 to 2% of IBD patients, typically occurs independent of disease activity, and often begins as a reddish papule or nodule, might look like erythema nodosum initially, but progresses to an ulcerated lesion, which may be very tiny or may become very large. There's a predilection for lower extremities, lower limbs, the legs, but with IBD, it can occur anywhere, including the groin, the buttock. If an individual has an ostomy, such as an ileostomy or colostomy, it has potential to involve that. And I've seen that multiple times. And the activity does not parallel the bowel disease, and it often requires treatment with topical or systemic steroids, cyclosporin, tacrolimus. These are agents that we typically don't use in IBD, and anti-TNFs are often effective. But when one has pyoderma gangrenosum, it's important to be working with a dermatologist who has knowledge and expertise with this condition, as well as your gastroenterologist. And this is an example of severe pyoderma gangrenosum, where there's been severe ulceration of the tissues, leaving a gaping wound. Psoriasis is the most frequently associated skin disease associated with inflammatory bowel disease, occurring about 10% of the time, and is often seen before IBD symptoms arise. And so, oops, let me go back. These are often the white scaly lesions that may occur on the back of the neck, at the base of the scalp, also known as the nape of the neck, but may occur on the elbows, very classically, can occur on the palms, can occur on the legs as seen on the right, and important to be working with a knowledgeable dermatologist to understand and characterize this abnormality and manage it best. So now we're going to talk about some of the hepatobiliary manifestations. And the main one that we'll touch on today is primary sclerosing cholangitis. And this is an autoimmune, just like Crohn's and UC being immunologic or autoimmune diseases. Primary sclerosing cholangitis is an autoimmune disease of the bile duct, and that leads to inflammation and stricturing of the bile duct. And it can progress and cause narrowing of the bile duct, and the bile duct drains the bile from the liver into the intestine, and that is depicted here. And this is an image, an ERCP, which is an endoscopic study of the bile duct, showing all this nodularity, a lack of the normal smoothness of the biliary tree, just telling us that there's something very wrong there that needs to be understood and characterized. 90% of patients with primary sclerosing cholangitis have IBD, okay? But only 5% of patients with IBD have primary sclerosing cholangitis. So this is an important distinction, something that's maybe a little hard to remember and keep in mind, but true primary sclerosing cholangitis is an uncommon manifestation of IBD, but when one has it, it is the gastroenterologist, maybe a liver specialist, who will be working together to best manage it. And again, primary sclerosing cholangitis, also known as PSC, as you see on this line for short, it's more common in ulcerative colitis than in Crohn's disease. And patients may be totally asymptomatic, or they may have some symptoms such as fatigue that's unexplained, jaundice, which is a discoloration of the skin or eyes, pruritus, which is a fancy medical term for itching. And again, all those symptoms are often a little nonspecific. It's PSCs, sclerosing cholangitis, is often diagnosed when we check blood work and we see that there's a new elevation of a liver test that we don't have an explanation for. And that's why we go ahead and do perhaps an ultrasound or a test called an MRCP, which is mentioned down there. And then if there are abnormalities found, we pursue this diagnosis more. But if those tests are normal, and maybe the liver test abnormality is due to some medication. Maybe it's short-lived and there's some other explanation as well. But again, these are very specialized conditions that require your gastroenterologist or liver specialist to help understand and manage. As far as complications of PSC, patients with it often develop low bone density, and this needs to be managed. The most worrisome things about catching this condition early is that it may progress, and it can progress to liver cirrhosis. It can even progress to a form of cancer of the bile duct called cholangiocarcinoma. And there is a higher incidence of colon cancer in patients with Crohn's disease and ulcerative colitis when they also have primary sclerosing cholangitis. So these are things to keep in mind, and this is why we do blood test monitoring and ask lots of questions, and that's why we like having you come back for follow-up visits, even if you're feeling well, so we can check and see if there are any important history changes or lab changes since the last visit. So let me just mention one thing is that there are limited treatments for something like PSC, but liver transplantation is actually one of the best treatments if it becomes exceedingly advanced and complicated. So in wrap up, I want to say that it's been a pleasure, sharing a few minutes with you. We've talked about the arthropathy, the peripheral arthropathy of IBD, the erythema nodosum, the episcleritis. These are, again, conditions that do parallel the course of the IBD inflammatory activity. And we've also talked about type 2 peripheral arthropathies, the really small hand joint and feet abnormalities, the axial sclerosing, the axial disease, the ankylosing spondylitis and sacroiliitis, skin abnormality like pyoderma gangrenosum, the more advanced eye disorders like uveitis and iritis, and primary sclerosing cholangitis, things that don't parallel or improve with treatment of the IBD and need to be managed other ways. So with that, I want to thank you for attending today. I want to thank you for your attention. And I think we'll have time for questions either now or at some later point. Mary, thank you very much.
Sure. Thank you so much, Dr. Wolf. Yes, we have some time for questions now. If you would like to enter them into the chat box, we did have an anonymous question come through, or two questions come through, Dr. Wolf. The first question is, it looks like it's referring specifically to ankylosing spondylitis. How is ankylosing spondylitis diagnosed?
Well, it can be suspected based on even the history. It can be diagnosed by physical exam and seeing the limitation that one actually has in bending over because there's limited range of movement of the back. Those are probably so you can really suspect it based on history and exam. It's confirmed classically by just a plain X-ray, where one can simply look at an X-ray. This is without any fancy CT or MRI, and see the fusing of the joints, and a radiologist can characterize that very well. Nowadays, everyone ends up getting a CAT scan or a CT scan or an MRI to characterize it further. And it's very important when I suspect a patient of having ankylosing spondylitis, I always involve a rheumatologist who is a specialist in this condition to weigh in on it and see and help manage that aspect of their inflammatory bowel disease.
Fantastic, thank you. And then the second question I was sent, is surgery ever needed for patients with joint manifestations? So I'm assuming they mean surgery specific to the joint manifestations.
That's a great question. And in decades of caring for patients with inflammatory bowel disease, I have never sent a patient to surgery for their joint manifestations, and I've never heard of that. So again, I think classically, if this is an IBD arthropathy, it doesn't cause the joint damage that is more characteristic or classic in advanced rheumatoid arthritis, where joint surgery has been performed many times in the past. Let me say that as far as the biologics, one of the great things that the anti-TNFs have done, and it may be effective with some of the other biologics as well, but it's not as well documented, is that these can really prevent progression of the severe joint manifestations, and certainly when associated with IBD, it would be the back manifestation. So it can prevent, it can halt the progression of ankylosing spondylitis and keep someone from requiring back surgery that has occasionally been needed for patients with the IBD back disease. So that situation is a little different. But when thinking about patients with rheumatoid arthritis, for which anti-TNFs are approved, that has far reduced the need for joint surgery in that population.
Perfect. Thank you so much. Thank you, Dr. Wolf. That was a really great presentation. At the moment, we don't have any other questions relating to extraintestinal manifestations. We have another one from Madeline that came through. I think we could go ahead and answer right now because we have time. Madeline's question is, might we touch on the biggest differences between IBS and IBD? It seems that both conditions include periods of flares. Many patients seem to be misdiagnosed with IBS for a period of time before assuming something more, such as IBD, is going on. Do you want to go ahead and take that question, Dr. Wolf?
Yeah, I'd love to. And then also I have a question that I'll ask myself after we get this one
Okay.
resolved. That might fill our time slot, but we'll see. So yeah, the differentiation, and again, the differentiation between IBS and IBD, so irritable bowel syndrome and inflammatory bowel disease, that could be an hour-long lecture or presentation or an all-day discussion. So, but we can make it very simple and try to do it in a minute. And the difference is that IBS, irritable bowel, does not typically have any inflammation associated with it when symptoms are active, and there is what might be termed an IBS flare. But the classic feature of inflammatory bowel disease flare, Crohn's disease flare, or ulcerative colitis flare is that there's an increase of inflammation that is triggering that flare, and that's why anti-inflammatories, and again, I'm not talking about aspirin or ibuprofen, I'm talking about gut-specific anti-inflammatories such as mesalamine, such as prednisone, a drug nobody wants to use but is effective, and biologics. These are all agents that are effective at controlling the inflammation related to Crohn's disease and ulcerative colitis, and thereby control the flare. The types of medicines that are used for IBS, well, let me say one more thing, and that is there's something called a Venn diagram that I can't draw you. Let's see. It's where you have two overlapping circles, okay? And one circle is IBS, and another circle is IBD, and there are a number of patients, a large number of patients who may have symptoms due to both. And so having IBD, Crohn's disease or ulcerative colitis, does not mean you don't have IBS. I'll say one more thing about that and then move on to my other question. And that is that, unfortunately, because maybe of lack of access to care and because Crohn's disease, even more so than ulcerative colitis, is really one of the most complicated conditions to sometimes diagnose. there have historically been incredible delays in diagnosis for many patients with IBD. And when records are reviewed, these delays are not just days or weeks or months. I mean, they're years. There are many documented cases of patients who've had symptoms that almost certainly represented active Crohn's disease or ulcerative colitis, and there have been delays of 3 years, 5 years, maybe even 10 years, someone making the diagnosis. So it's very important if you have or you know someone who has symptoms that aren't getting answered adequately or managed, to see a gastroenterologist who can perhaps take another look and see if there is more Crohn's disease or ulcerative colitis going on, or maybe a new diagnosis, something along those lines. The other question that I wanted to ask myself and everything to just put it on the table related to extraintestinal manifestations is the fact that some patients don't have any extraintestinal manifestations. And I've seen patients, I have patients who've had Crohn's disease or ulcerative colitis for 30 years, 40 years, 50 years, and they've never had an arthralgia. They never had a mouth ulcer. And then there are also patients who present for the first time with joint aches, mouth ulcers, and liver abnormalities. So there's a whole range, a whole spectrum. And that's, again, one of the things that's so interesting, fascinating, but challenging about Crohn's disease and ulcerative colitis, that there is so much variation. But I do want to get that across, that perhaps as many as 50% of patients with Crohn's disease and ulcerative colitis don't have extraintestinal manifestations as part of their condition, but another 50% in the literature do. And those numbers, do's and don'ts, they might be higher or lower depending on how carefully, how good a history is taken and how much high-tech examination is done. So, but not everybody has it, and that's the message I wanted to share.
Fantastic. Thank you so much.
You're very welcome. It's my pleasure.
All right, so now we are going to move on to Dr. Heba Iskandar. She is going to share her screen, and she is going to present on pain and fatigue in IBD. And we will give her just a moment to share her screen. Dr. Iskandar, can you hear me okay? There you are.
Hi. Let me just share real quick.
Sure, take your time.
All right. Well, I'm very grateful also to be talking to you guys today about this topic of pain and fatigue and IBD. And I know in the national front, in the Crohn's and Colitis Foundation, Patient Education Committee, and even website, I've been heavily involved in this topic, and relaying, one, that we do care very much about this, and two, that we would love to help. So pain and IBD can come from many places, and I think everybody on the call has probably experienced one or more of these, and this is a throwback definitely to Dr. Wolf's extraintestinal stuff, that it doesn't just have to be the abdomen, but there can be stress, fatigue, can cause headaches. There can be eye manifestations that can be painful, mouth ulcers, joint inflammation, back pain, like we were talking about, ankylosing spondylitis, and the skin, of course, can have painful manifestations, and then the abdomen, which is the most classic one that we think about, from either inflammation itself or narrowing in the intestine. or from the interventions we do to treat complications of inflammatory bowel disease like surgery. Some people will have pain from kidney stones, which are higher rates in inflammatory bowel disease patients. And then perianal pain, of course, from either abscess or fissures. So there's basically a lot of pain that can happen in IBD, and we understand that it really affects our patients' quality of life. And so in terms of the abdomen, we talked about severe inflammation, which can release some chemicals to the brain that signal the presence of pain, and strictures, which can cause backup of, bowel contents that can be very painful and lead to vomiting and obstruction. Fistulas, which are abnormal connections between the gut and another organ, either another part of the intestine or the skin, or even the bladder sometimes, and all those things can cause pain. Bacterial overgrowth that many of our patients experience potentially after surgery or with a J-pouch surgery, that can lead to bloating, cramping, and distension or swelling in the belly. Extraintestinal pain we just talked about, and then all anxiety and depression is higher in our IBD patients, and that can have a role in increasing the sensitivity to pain in the intestine, from the intestine as well, because of the big connection between the brain and the gut. So we established it can hurt, IBD can hurt, and we like to increase awareness of how to treat this with medications that could be effective but have a lower side effect profile. And then what I'm going to talk about can be applied to both Crohn's and ulcerative colitis. So what are our tools? What is in our toolbox in terms of medications? So we're all medical doctors, and medications are, the way we manage many things. And first, there's of course steroids and steroid-sparing therapies like biologics that can treat the inflammation itself, and that can secondarily help with gut pain. But as you guys will hear, I probably already just heard, and we'll hear some more, that we limit the use of chronic steroids, and we try to get patients on another therapy that can get us off the steroids, like a biologic therapy, for instance. I've listed some of the side effects of steroids here, but I think everybody who's taken a steroid knows that it's no walk in the park. And so we reserve their use for just very short-term flares, and always we need an exit. We need an exit strategy. So usually another medication to get us off. And then NSAIDs, and Dr. Wolf just mentioned those as well. So those can help inflammation and joint pain. However, they can increase the risk of IBD flares in the gut. And so we try to avoid them or use them very sparingly in special situations, but definitely not without the advice of your gastroenterologist. And Tylenol is really a safe over-the-counter choice for inflammatory bowel disease for patients without liver problems, and that can be a pretty good one to reach for as well. Antispasmodics can be very helpful in an as-needed capacity. They're really pretty well tolerated, and they can relieve the intestinal spasms from inflammation, especially, for instance, in an ulcerative colitis flare. There can be spasms in the colon, or from partial obstructions or chronic strictures. And they can also help with gut sensitivity, or what we call functional pain. And there are some potential side effects: dry mouth, blurry vision, drowsiness, especially in patients who are over 65 years old. However, use intermittently is pretty well tolerated. The other modality to treat pain is antidepressant family of medications. And antidepressants are really commonly used. We talked a little bit about IBS and IBD and their overlap in the questions before, but they're pretty good at treating pain in IBS, and they're really helpful as well for treating chronic pain in IBD patients, and they're really commonly used. And so probably almost 40% of IBD patients are taking advantage of the pain modulating effects of these medications. And the classic ones are the SSRIs and the SNRIs. And we really don't know if it's just an impact on the intestinal pain or also an increased ability to manage the pain by decreasing anxiety and depression. One thing is, if you start on these medications, you do need to come off gradually if you decide to try to taper off of them and not suddenly. Tricyclic antidepressants are also a favorite. We can use them in very low doses that have a limited side effect profile, and these the addition of these, especially if you find that your inflammation is controlled, but there's still some pain, can be very helpful to manage that as well. Sometimes patients end up on types of anticonvulsants like gabapentin or pregabalin, and they can also treat the sensitivity or the neuropathic pain, they can also cause some drowsiness and take a while to work. So those are some of our medication tools, and I know I left out a big one that I'll address in the end, which is the opioids, but treating pain can also involve some non-medication based methods. So psychological treatments or psychotherapies can really help IBD patients. There's a lot of data about gut-directed hypnotherapy that has actually shown some ability to prevent flares even, cognitive behavioral therapy, which can be used to treat anxiety and depression that are heavily associated with inflammatory bowel disease and can lead to a decreased focus on the pain and improvement in the quality of life. Some other therapies, so medical cannabis or CBD oil has been shown to be able to improve some of the symptoms. However, there's no evidence that it can reduce the inflammation itself or improve disease activity. Exercise and physical therapy, so in some cases pelvic floor muscle training, or exercise to help with improved muscle mass. There can be a lot of muscle wasting in IBD with severe disease. Even in some cases, yoga has been helpful for symptom of abdominal pain. And then some mind-body stress management techniques like meditation, mindfulness, and participating in support groups through, for instance, the Crohn's and Colitis Foundation, as I imagine many of you already do. And then even acupuncture in some studies has shown a benefit for diarrhea. So there's a pretty good number of tools, and finding, what works for you is really the key thing here. One thing that's not on this list also to mention is dietary changes. And I think that, sometimes when the same thing, especially if the inflammation is controlled, going on, for instance, a low FODMAP diet or certain low processed food diets can be very helpful to control those additional symptoms that are there. And that's also extrapolating somewhat from the IBS data. So then I'm just going to spend a few slides on the opioid medications. And this group of medications has received a lot of attention lately in the press with increased rates of death and in the chronic use of these patients. And it's really a public health measure to limit their use. They're medications that are pretty strong, can help manage severe pain, however, have significant side effects. And so in IBD, I use them even less than I use steroids, and I try to limit them to very short periods of time of very severe acute pain that is associated with a sudden change in health. So most commonly after a surgery, but even after surgeries, they're starting now to limit the use of opioid medications. And my own mom had got surgery, for instance, and she took Tylenol and Toradol and Tramadol. And so they're really, really trying to limit the use even then. So very limited usage basically. And things to consider before beginning an opioid is thinking about what other treatments, like the ones we listed before, could be used instead, and thinking about the duration. So if there is a surgical scar that's healing, or a perianal abscess that's going to be drained in the coming few days, then that's a much more acceptable duration. However, chronic pain is problematic when opioids are used, and I'll go into why. So opioid side effects. So in the short term, so say there's a perianal abscess and it's very painful and you're prescribed an opioid, you probably will experience some constipation. So asking for a stool softener or a laxative could be helpful. Nausea and vomiting, which really get worse with prolonged use. Drowsiness or sleepiness. So of course, patients are told not to drive or make decisions on these medications. And then that they can interact with other medications that are already prone to causing drowsiness. Sexual dysfunction, a lot of patients experience itching, or in extreme cases, confusion. And opioids increase really the duration of staying in the hospital, the rates of readmission, and the rates of infection, and really don't help the quality of life in the studies that this was looked at in. And then in the medium and kind of long term, they can worsen anxiety and other mood disorders, and they can interact with a lot of other medications, slow down the gut, which can affect swallowing, emptying of food out of the stomach, colon motility, and result in more constipation. And there's even a syndrome called narcotic bowel syndrome, which almost potentiates abdominal pain as well, and is a very tough one to treat. And then it can cause small intestinal bacterial overgrowth, where there's overgrowth because things are not moving, very similar to, a pond without waves or something like that. And then withdrawal symptoms, and then of course addiction. And then really long term, it can increase the risk of death due to complications of IBD. So I think that that's a pretty long list, and enough hopefully to motivate most doctors and patients to try their best to avoid this group of medications. And then moving on to fatigue. Fatigue is a very frequent symptom for IBD patients, and it's an overwhelming sense of being tired, not having energy, feeling exhausted that often is not improved after you rest or sleep. And it affects a lot of patients with active disease, about 80%, but also 50% of patients who are even in clinical remission. And there's even some studies to show that fatigue can increase over time, even when the remission is maintained. And so that's a very tough symptom to treat, admittedly, for patients and providers. So fatigue, the reason it's a tough symptom is because it can have a lot of causes, and the causes can be shared in terms of more than one etiology in the same patient, which makes it very hard to treat. And requires usually some workup. So when people present with persistent fatigue, we always take a second look at the inflammation levels. Whether by non-invasive markers like blood and stool tests, or even by endoscopy, to try to figure out, are they having fatigue secondary to inflammation, as chemicals and inflammation hormones that are made during inflammation can cause tiredness and lack of energy. And so that's one thing to check off the list. And I do look at fatigue workup as a list of things I want to cross off for the patients. Anemia is possibly a big player in fatigue, and IBD patients with anemia basically don't have enough red blood cells to carry around oxygen to the tissue, so they can have a lot of trouble with fatigue, even with minimal activities. They can have shortness of breath, and they can have an inability to exercise. And so looking for anemia and then treating the cause of anemia is going to be very important. Deficiencies in some of the vitamins and minerals. So low iron, which can of course secondarily cause anemia, low B12 and folic acid, they can cause fatigue on their own right. And then even some other micronutrients that patients with severe small bowel disease, they can have other vitamins and minerals that are low that can contribute to weakness and fatigue. And medication side effects are helpful to check. Some of the medications that we commonly use, the immunomodulators like azathioprine, 6-mercaptopurine, can contribute to fatigue. Steroids usually cause poor sleep, which can cause some fatigue in patients, but some patients experience an increase in energy with that as well. And of course, the antidepressants and all the medications we mentioned before, antispasmodics, narcotics, those or opioids, all those can cause fatigue. Pain and inflammation in the joints, even in the absence of gut inflammation, can lead to fatigue. And then poor sleep. So say the symptoms are interrupting sleep, so night diarrhea or abdominal pain or urgency or incontinence of stool in the nighttime can interrupt and lead to a lot of fatigue in the daytime. Or psychological comorbidities like depression and anxiety can lead to poor sleep, which can secondarily cause fatigue. And then fatigue is something we really have to consider also other things that are not related to inflammatory bowel disease, like thyroid disease, obstructive sleep apnea, deconditioning, and any other uncontrolled illness that could be unrelated to inflammatory bowel disease. So that's some of the causes of fatigue. Treatment and managing of fatigue can be tough, and admittedly as a doctor, and I think all the others will agree, when you have somebody complaining of fatigue and sometimes you can't find anything, but you have to manage their iron and vitamin deficiencies, and reconciling all the medications, reviewing those and seeing which is associated with fatigue, reducing psychological and emotional stress by exercise, meditation, cognitive behavioral therapy, getting help with sleep itself, and then of course managing any active inflammation, whether it be joint or gut inflammation. So treatment of fatigue has to be successful, in my opinion, has to have multiple modalities. If there's no inflammation and there's no deficiencies, fatigue, I think, is better managed with the help also of the primary care physician and maybe even a psychologist. There is a lot of interest and research going into treatments of fatigue, and hopefully soon we might have treatments directed just at IBD related fatigue. So in summary, basically, your doctors do want to help with pain and fatigue. Openness about what you're experiencing is the most important thing, and that we're here to help even with symptoms that are sometimes difficult for us to treat, and kind of taking the approach that gradual changes may eventually make a big difference in the quality of life, where things are less frequent, less severe. There may not be a magical pill for any of these issues. However, focusing on gradual improvements over time is really important. Having a lot of open communication, and then defining the goals. What is the most important to you? And I'm often surprised by my patients' goals that, the doctor often says, well, my goal is to treat your Crohn's and get it in remission. And the patient's goals are a lot more important and a lot more relevant to their real life. Like, I want to attend, this wedding, or I want to not get up at night, and different things like that. But sharing and kind of coming to a middle ground for the sharing and the treatment decisions is really important. And like I mentioned before, there's a lot of interest in these areas of fatigue, pain, and sleep management with psychotherapy and medications, and hopefully will help in the future with living with IBD, which we know can be a challenge. So here's some resources, and I'm happy to take any questions.
Fantastic. Thank you so much. We did have one anonymous question come through, and that question is, what about medications like Xanax for treatment of pain? Can those be helpful?
So Xanax is not one that I usually reach for to treat pain. Xanax is really an anxiety treatment, and it's better used for limited duration. So for like a panic attack, for instance, instead of for chronic management of anxiety. And certainly having a psychiatrist to help with managing that medication is going to be very important, as it can lead to dependence or addiction on it. And so using it on a regular basis to manage pain is not something that I usually do. And then also with the caveat that in certain select situations, intermittent doses can also help with nausea, and that I have done. But basically, the key to Xanax is very sparing, very intermittent use.
Okay, thank you. I think that answered the question. If anybody has any additional questions for Dr. Iskandar, you can enter them into the chat right now. Otherwise, we can move on shortly to our next presentation. And while I'm bringing up the next presentation, I would like to mention Dr. Iskandar highlighted some of our support groups that the Crohn's and Colitis Foundation hosts. We have 3 support groups that are meeting virtually, and 2 of them meet monthly. One is hosted by the Crohn's and Colitis Foundation volunteers, and that meets, I believe it's either the second Tuesday or the third Tuesday of every month. We also have one that meets every other month, and we partner with Atlanta Gastroenterology Associates. Dr. Asia McCutcheon and Allison Moe, who's a physician's assistant, helps moderate and lead that group. And we have a new group that's starting again on Tuesday of next week. It is a group for parents, and we'll have a breakout session for teens. So if you have teens that are in 9th through 12th grade, we do have that virtual support group as well. And I did put in information into the chat about those support groups. So if you have any additional questions, we do have a question. Dr. Iskandar, we have one. Is Lexapro an effective SSRI to manage Crohn's disease pain?
It can be if the pain is in the absence of severe inflammation or more than the inflammation that is seen. It can be very effective in managing the gut sensitivity component or the IBS that's overlapping with the Crohn's, and also in managing anxiety or so that can heighten this awareness and experience of the pain.
Okay. Fantastic. Thank you so much. I think that was the last question. So now we are going to view a presentation that was pre-recorded by Dr. David Rubin. Dr. Rubin is our incoming National Scientific Advisory Council president, and he is a world-renowned physician and gastroenterologist at the University of Chicago. He has pre-recorded a presentation about steroids in IBD and risks in relationship to COVID-19. And we will also have Dr. Tan Vidair available after this presentation is completed. So she and the other doctors can answer questions that are specific to COVID-19. Once that's complete, we will open it up for general questions and answers. So we will get started with this in just a moment.
The National Scientific Advisory Committee of the Crohn's and Colitis Foundation. Today, I'm going to be speaking about steroids in inflammatory bowel disease, and specifically some of the recommendations and our understanding about steroids and COVID-19. Although this presentation has been supported by an educational grant from Janssen Pharmaceuticals, and I have previously consulted with them, the content was developed by me and my comments are all my own, as have been all the other slides that we've prepared for this presentation. In inflammatory bowel disease, it's important to remember that the condition is characterized by an overactive inflammatory system. The immune system of the intestines, which is there to protect us, is in overdrive, either because something is continuing to stimulate it or because our body has lost the ability to regulate it or to shut it down or turn it off. Therefore, our therapies for inflammatory bowel disease have predominantly been focused on addressing this overactive immune response. So it's often misunderstood that medications we use that might modify or even suppress our immune system have the goal of causing immune suppression. The reality is that our actual goal is just to turn down the overactive immune response long enough so the body can
I apologize, everyone. There was a slight technical difficulty. I'm going to fix that.
My name is Dr. David Rubin, and I'm a professor of medicine at the University of Chicago. In April 2021, I will be the chair of the National Scientific Advisory Committee of the Crohn's and Colitis Foundation. Today, I'm going to be speaking about steroids in inflammatory bowel disease, and specifically some of the recommendations and our understanding about steroids and COVID-19. Although this presentation has been supported by an educational grant from Janssen Pharmaceuticals, and I have previously consulted with them, the content was developed by me and my comments are all my own, as have been all the other slides that we've prepared for this presentation. In inflammatory bowel disease, it's important to remember that the condition is characterized by an overactive inflammatory system. The immune system of the intestines, which is there to protect us, is in overdrive, either because something is continuing to stimulate it or because our body has lost the ability to regulate it or to shut it down or turn it off. Therefore, our therapies for inflammatory bowel disease have predominantly been focused on addressing this overactive immune response. So it's often misunderstood that medications we use that might modify or even suppress our immune system have the goal of causing immune suppression. The reality is that our actual goal is just to turn down the overactive immune response long enough so the body can reset itself and take over and go into a resting phase. It's also nice to remember that the bowel has an immune system that gets activated every time we eat. People who don't have inflammatory bowel disease, as well as those who do, become mildly inflamed with every food item that we swallow and expose our body to the outside world. Normally, the body will then shut itself off, Or if we were to get food poisoning or a viral infection, the gut immune system can become much more active. But in people without inflammatory bowel disease, this shuts itself down. In IBD, as I've mentioned, the condition of the immune system of the bowel is overactive. And that overactive immune system is what causes damage to the bowel and causes symptoms that our patients experience who have Crohn's disease or ulcerative colitis. The different therapies we use to treat inflammatory bowel disease can be divided into some categories. You may be familiar with some of the treatments because you've been receiving them, or your family member who has inflammatory bowel disease is receiving them. Antibiotics are used to address certain types of Crohn's disease primarily. They do not suppress the immune system. Aminosalicylates, or sometimes called 5-ASA therapies, or mesalamine or sulfasalazine, do not suppress the immune system either. They are believed to work more topically on the lining of the bowel. Immunomodulators, also considering therapies called thiopurines or methotrexate, can suppress or modify the immune system. These are older therapies that we still use in some patients, and it's important to understand how they work. Steroids will be the focus of most of this presentation. We'll talk a bit more about them. When it was appreciated that steroids could treat inflammatory bowel disease, it was considered a revolution in the management of these difficult conditions. We've learned a lot more about steroids since then, and I will be teaching you about that. Biological therapies are proteins that have been designed to target certain components of our immune system. They're called biologics because they're actually made by living cells, and then the protein that's made by those cells is used to target other inflammatory proteins in our bodies. There are different classes of biological therapies that work on different targets in our body. Some of them are more systemically acting, where they'll affect the entire body's immune system, and others are more targeted or selective in their activity and have a more favorable safety profile. And lastly, we have a newer therapy that is oral and is called a targeted synthetic small molecule. And this specifically inhibits an enzyme called Janus kinase. So even though this is an oral therapy, it's actually more systemically active and immune suppressive in its activity. So let's focus more on corticosteroids. As I mentioned, it was a revolution in the management of Crohn's disease and ulcerative colitis when it was discovered that steroids could treat these conditions. And they have been demonstrated repeatedly to be effective for inducing remission or at least controlling symptoms of both ulcerative colitis and Crohn's disease. Unfortunately, we shortly thereafter appreciated that there were risks associated with steroids, and these risks were worse with higher doses and with longer exposure. The risks include an increased risk of infection, psychosocial impact in terms of how it affects people's ability to sleep, either falling asleep or staying asleep. It can affect mood and make people more irritable or even trigger anxiety. And there can be other neurological changes or changes in physical appearance, including weight gain, skin fragility, which makes it more sensitive to injury, acne, or swelling. These side effects are especially noticeable when people have been on higher doses of steroids for a long time. Short doses of steroids or lower doses do not have the same effect on the body. There's also been a well-described effect on development and growth in children who are exposed to steroids too long. And we also know that people who've been exposed to steroids lose bone density and may be at increased risk for fractures. That's especially true in older individuals who are on steroids. It has been recommended that when patients are on steroids for any period of time longer than 2 weeks, that there is a period of time where they're tapered off of them rather than stopping them abruptly. Unfortunately, the taper schedule is not truly scientific and often goes on much longer than is needed, and we'll return to that message shortly. There are a variety of different types of steroids, whether they're oral, intravenous, or delivered rectally. And you can see some of the names there listed with some helpful icons so you understand whether they are oral or rectal. Budesonide is a type of steroid that, although it's taken orally or can be delivered as a foam in the rectum, has very limited systemic toxicity. The drug is essentially active on the lining of the bowel, and any amount that gets into the bloodstream is immediately cleared from the body. So budesonide at the doses that we use it is a steroid that in Crohn's disease and ulcerative colitis does not have the same side effects as prednisone. These are therapies that for the most part are for milder types of Crohn's disease and ulcerative colitis. Hydrocortisone, methylprednisolone, and prednisone are the more commonly used oral therapies, as well as rectal preparations that can be used in our patients. And many patients are familiar with prednisone as being the steroid that is most often prescribed. It has been recommended that when steroids are needed and when it's possible, budesonide preparations are used before getting to more systemic or higher doses of prednisone, hydrocortisone, or methylprednisolone. And this is because we want to start with therapies that work predominantly on the bowel before we go to more systemically active steroids. And the safety profile and the better tolerance of these budesonide preparations makes good sense. Rectal steroids are used because when we want to treat the rectum, which is inflamed in some patients with ulcerative colitis and Crohn's disease, we want to get the drug exactly where the disease is, and it makes more sense to treat it topically than to expect that oral therapy may either get to the rectum by getting through the entire intestinal tract, or that we use systemic therapy when a topical therapy in the rectum might be easier. These can come as suppositories that are inserted into the rectum, or as enemas, or as foam. The foam tends to be better tolerated and easier to hold on to. These are also steroids though, so even though there's very limited systemic effects of all these steroids, you should remember that they're still steroids and they're not going to achieve long-term control, and we do want to move beyond them after we get patients on better treatment options. There's a few comments about steroids that I'd like to share with you. The first one is that although steroids are good at controlling symptoms, they do not actually heal the bowel. They actually impair the bowel repair. So what happens is that it reduces the inflammation, but it has a contrary effect in which it's actually inhibiting the bowel from restoring itself. So while they may make patients feel better, they're not often able to get them to a stable place of control. Therefore, we use steroids as a marker of somebody who needs to be on what's called a steroid-sparing maintenance therapy. That means that by the time a patient needs a steroid, we should be thinking ahead to what treatment are we going to use that will keep them in remission and also keep them off steroids in the future. In general, my colleagues and I think that a patient who needs steroids more than once in a year needs to be on a more effective maintenance strategy. In addition, as I mentioned, patients who've been on steroids for longer than 2 weeks at doses at more than 10 milligrams do need some kind of taper schedule. However, most people end up tapering longer than is necessary. The time for tapering is a combination of how long the patient was on the steroid in the first place, but also how long it takes for the steroid-sparing medicine to get up to its full effect. In other words, we use the steroid as a bridge until the new medicine can take over. And this is a very important concept to keep in mind. We often find that people taper very slowly over many, many weeks, when in fact the new medicine may actually kick in within 2 to 4 weeks, and the patient could be safely off their steroids if it's doing its job by that time. Now I'd like to change the topic a little bit and talk about COVID-19, but specifically about steroids in COVID-19. And in order to do that, I want to explain a few things that we've learned about COVID-19 and the risks in patients who have inflammatory bowel disease. The first one is that there have been a number of publications now, as well as a consensus statement by the International Organization for the Study of IBD. And in all of these different documents, we have recommended that keeping the patients with IBD in remission is key to keeping them healthy during the pandemic. The last thing we want is for patients with Crohn's and colitis to have a relapse of their disease and require hospitalization or require to be put on steroids to get that under better control. As you look down this table of the different medications, you can refer back to what I already described as the different types of therapies we use. And you can see in the far right column what the recommendation is based on the different types of therapies. For example, the aminosalicylates, which we don't think have any effect on our immune system, it's been recommended you stay on them and you take them as prescribed through the pandemic. In addition, the immunomodulators, the biologics, and the JAK inhibitor, that oral small molecule therapy, we've recommended that patients stay on them during the pandemic unless they get infected. We'll come back to that in a moment. It's been recommended and it's been observed that these therapies are safe and stable for patients to be on during the pandemic. You'll note, though, that steroids are the exception in which the consensus opinion and the emerging data support that patients who are on higher doses of steroids should be off those steroids safely in order to be protected from potential adverse events if they get infected with the coronavirus. This is not new from our general recommendation about steroids anyway, so it makes good sense to keep that in mind. If you are on steroids for your inflammatory bowel disease right now, you should be having conversations with your healthcare team about how you can safely get off of them. And lastly, for antibiotics in general, we think those are safe to stay on if you need them. And again, those are for specific types of Crohn's disease mostly. In order to understand COVID-19, I wanted to share this helpful graphic. I just want to point out to you that there are two main phases of the infection with the coronavirus. The first phase, which is listed here as stages 0 and stage 1, is when a healthy person becomes infected with this novel coronavirus, SARS-CoV-2. The infectious phase of COVID-19 is when someone feels like they have the flu. They may have a fever, a dry cough. They may even have digestive symptoms, headache, or loss of taste and smell. This is what is the most common symptoms that patients will have, and many people, including patients with IBD, will recover from this uneventfully. The later stages is the second major phase. It's the inflammatory phase of COVID-19. This is where people get into trouble. Some individuals have the infectious phase become an inflammatory phase where the body's immune system is making too many inflammatory proteins, and this is what results in pneumonia and lung congestion, shortness of breath, hospitalization, intensive care units, ventilators, and sometimes death. The inflammatory phase is just like the overactive inflammatory phase of Crohn's disease and ulcerative colitis. So it's been of great interest to us to learn that some of the medicines we use to treat Crohn's and colitis may actually reduce the complications seen in the inflammatory phase. It's a very important concept, and it's also important to keep in mind these two different phases. The infectious phase, where someone has the virus and feels like they have the flu and may recover uneventfully, and that inflammatory phase, which happens less often but is much more dangerous. There have been a number of different studies on steroids related to the coronavirus infections and specifically related to COVID-19. There was a severe acute respiratory syndrome epidemic that occurred in 2002 and 2003. That's now referred to as a virus called SARS-CoV-1. It was the original SARS-CoV. And what they learned in that particular epidemic was that steroids made the disease worse, and patients seemed to be more susceptible to complications from the virus when they were on steroids. They also learned that steroids resulted in slower clearance of the virus from the blood and even a higher rate of death. And this wasn't just IBD patients at all. This was the general group of people, because when they developed this severe acute respiratory syndrome, the doctors tried treating them with high doses of steroids and they didn't work. And in fact, it seemed to make patients worse. However, more recently, and you may have seen this in the news, there was a randomized study performed in the United Kingdom where patients who were already hospitalized and needing oxygen or mechanical ventilation received a steroid called dexamethasone, and they were actually able to do better than those who did not receive dexamethasone. And the distinction between what was seen in the SARS, the original coronavirus, and what we think is true for this coronavirus, and what was found in that UK study is dependent on the phase in which we might have treated those individuals. In other words, When you're on steroids, when you get infected, you may actually do worse. But if you use steroids further down the line, when you're in that inflammatory phase, it may have some benefit. And I wanted to point that out to you because that's led to some confusion about the messaging regarding steroids in our patients with inflammatory bowel disease. Now, a couple of recommendations regarding how to handle this in terms of your management and considerations if you've been tested. If you find out that you have SARS-CoV-2, but you have yet to develop any symptoms of COVID-19, I hope you don't develop any symptoms of the COVID-19 disease. But if you test positive because you were exposed to somebody, or maybe at work you're required to be tested, the recommendation is, if you're on steroids, to make sure that you work with your healthcare team to get to lower doses. And if you're on other immune modifying or immune suppressive therapy, you actually stop them for a couple weeks to allow your body to either develop the COVID-19 and hopefully recover quickly, or to not develop it at all. And after 2 weeks, you usually know that that is or is not going to happen. If you stop the therapy, it should be under your doctor's recommendation and observation. And of course, you should be communicating with them. In terms of when you would restart the therapy, well, if 2 weeks go by and you haven't had any problems at all, you can restart your therapies safely. If you did develop COVID-19, the consensus recommendation is after 3 days with no symptoms, that includes no fever, you can restart your medications safely. Now, there's a little bit of detail here that's worth mentioning. Many of the medicines you're on, whether they're biological therapies or those oral immunomodulators, have half-lives that make them longer lasting in your body. In other words, even if you stop it for a week or two, the medicine's still there. So it doesn't always make complete sense that you'd be off your medicine for 2 weeks when we know the medicine is still in your system. Nonetheless, that's our current suggestion. There are ongoing studies that so far have shown that some of these medicines may actually be used to treat the more severe COVID-19. And it may come to be that in the future, we won't have patients stop their medicines during this at all. I also hope that in the future, when we have a vaccine, this will all be a moot point and we won't even be worried about it any longer. If you do develop COVID-19, as I mentioned, you should be communicating with your doctors, you should be working with your healthcare team, and obviously focusing on your recovery from this infection and the consequences of it are really important. And I've already gone through what you should do with some of your medicines. It's the same as if you tested positive for the virus, but didn't have any symptoms of COVID-19. It's important to know that in the large international registry of patients with inflammatory bowel disease who developed COVID-19, we've learned that the main risks of having problems are related to the same things we've seen in the non-IBD population. More specifically, we're up to over 2,400 patients in this worldwide registry, and being older than 65, having other comorbidities like high blood pressure, diabetes, or heart disease, or possibly lung disease, and possibly being overweight. If you have more than 2 of those, you are at higher risk for having problems with COVID-19. And being on higher doses of steroids at the time of diagnosis are all associated with a greater likelihood of having worse outcomes. When you don't have those comorbidities, and if you're young, regardless of having Crohn's, colitis, a J-pouch, or an ostomy, your outcomes are like the general population, meaning most people recover uneventfully and do just fine. And so this very important international registry has educated us quite a bit about who gets this and what risk factors they may be. And for the most part, it's been really reassuring. In fact, one of their analyses demonstrated that patients who are on anti-TNF therapies, like infliximab and adalimumab, were less likely to end up with certain bad outcomes, again suggesting that they may actually protect against that inflammatory phase of the illness. The general recommendations remain the same as what you've heard on the news, and they're really important because they work, and we try very hard not to politicize public health measures. Wash your hands carefully and learn how to wash your hands correctly. Many people forget to wash certain parts of their thumbs and in between their fingers. Do it properly. Stay at home if you can, and if work will allow you to do so, and do telecommuting as well as other virtual ways of having meetings whenever possible. Wear a face mask when you leave your home. even if you live in a place where many people are not doing so. It is currently the best way to protect yourself, and if you're sick, to protect others. Make sure you're practicing social distancing, whether you're at work or in other places. Don't get into a crowded elevator and avoid crowded situations where you're not going to be able to have that kind of distance. And remember that you want to keep surfaces clean. That includes if you touch surfaces like door handles or elevator buttons, make sure that you're sanitizing your hands afterwards, or use something else to push or hold those handles and buttons. And make sure that you learn the proper way to cough and sneeze into your arm rather than into your hands, or certainly not into the air around you. So to summarize, there's a few recommendations regarding COVID-19 and our inflammatory bowel disease patients and steroids. And for the most part, we've learned quite a bit. And I think that overall, this is to be reassuring. Follow social distancing recommendations and practice good hygiene. Wear a mask when you're leaving your home. Stay on your inflammatory bowel disease medications so that you can stay in remission, and be reassured that the medications we use to control your IBD may in fact protect you from certain outcomes from COVID-19. Of course, notify your IBD healthcare team if you test positive for SARS-CoV-2 or if you develop symptoms of COVID-19. And remember, one of the main messages of this presentation is that while steroids were revolutionary for the control of inflammatory bowel disease, we've learned that using them long-term is not acceptable even before a pandemic and certainly during the pandemic. And you should be having communications with your healthcare team and with an IBD specialist about getting on medicines that can keep you off steroids and keep you healthy long-term. I encourage you to visit the wonderful Crohn's and Colitis Foundation's website at www.crohnscolitisfoundation.org for more information about all of this, but specifically their very helpful coronavirus website. Thank you very much.
Okay, wonderful information was shared. And I could not see the chat, but it looks like there was some very good questions that came in. I'm going to turn it over to Dr. Tanvi Dare with Emory. Dr. Dare, were you able to look at some of these questions that were in the chat?
Yeah, really great questions. So one of the questions that came up, it's a COVID medication related question. The question notes that the COVID IBD registry points to an elevated risk of developing COVID in patients on thiopurine monotherapy and combination therapy with infliximab. What is the risk of methotrexate in combination with infliximab? That's a great question. So just keep in mind, in terms of the data that seemed to suggest that there was a higher risk of developing COVID in patients who are on monotherapy with thiopurines or combination therapy with infliximab, were primarily in patients who are also older, so greater than 50 years of age, and also had multiple comorbidities or greater than 2 comorbidities. In terms of the actual risk of methotrexate, the sample size for the secure registry was quite small for that subpopulation. So we can't really say yes or no in terms of what the risk of methotrexate would be in combination with infliximab. But at the end of the day, it's still important, like Dr. Rubin mentioned, is to follow all the appropriate measures in terms of wearing a mask, social distancing, as well as aggressive hand hygiene as well. The next question was also alluding to the COVID IBD registry. Does the data gathered from the COVID IBD registry include information on high dose infliximab, or is it just reflective of standard dosing? Is there an increased risk of poor outcomes for patients on higher doses of infliximab? That's a great question as well. The secure registry wasn't designed in terms of how they gathered the data to determine whether it was related to either higher dose or just reflective of standard dosing in terms of the risk of COVID. But again, the higher risk of COVID was primarily in patients who were elderly and who also had multiple comorbidities as well. The next question that came up in the chat is there a way to slow down infliximab metabolism in the absence of antibodies? And so certainly when a patient develops antibodies against infliximab, there's an increased risk of clearance of the drug. There's certainly other factors that may affect how rapidly the medication is cleared from the system. That can include things such as obesity, elevated inflammatory burden, gender. We know that men tend to clear the drug faster as well. So in terms of ways that you could prevent the medication from being rapidly metabolized, that can entail adding, for example, an immunomodulator such as mercaptopurine or azathioprine or Imuran or methotrexate to help slow down the metabolism of the drug and keep the drug in more. And the other way too, as well, as potentially using higher doses of the drug, that may also help in terms of keeping an adequate level of drug in the system so that one may attain clinical remission. The next question that came up, is there a COVID-19, if there's a COVID-19 vaccine released, should IBD patients wait to get it? I think that's certainly a very poignant question with everything that's going on in the news now. And as probably all of you are aware, there are 2 vaccines that are going to be available by the end of the month, the Pfizer and the Moderna COVID vaccines. And I believe that with these vaccines, we're certainly going to be much closer to ending this pandemic. The FDA is meeting in the next 1 to 2 weeks with the vaccine regulatory agency to determine emergency use authorization for both of these vaccines. So it's likely that both of these are going to be available soon. So taking into account, whether somebody who has inflammatory bowel disease should get the vaccine or not. When we take a look at vaccines, the 2 biggest points of vaccines that we are concerned about is number 1, the safety, and number 2, is it going to be efficacious in our population? So with the 2 vaccines, the Pfizer and the Moderna vaccines, what we know is that they both are safe as well as efficacious. Based on the data that's available, there appear to be no serious safety concerns regarding either of the vaccines. From an efficacy standpoint, we know that they both are close to 95% effective when you get both of the doses separated by 3 to 4 weeks apart, depending on which vaccine you were to get. What's also important to note, even though that they weren't 100% effective, specifically with the Moderna vaccine, there were no serious COVID cases that were reported in those patients who did get the vaccine. So although patients may have gotten COVID-19 when they did get the vaccine, they certainly didn't appear to develop the serious form or the life-threatening form of it. The Pfizer vaccine was also very close to achieving this. Only 1 patient who received the vaccine did develop serious COVID in that particular trial. So this is certainly all very reassuring data, but like many of you know, these studies did not include patients who had IBD or who were immunosuppressed. They also excluded patients who were thinking about getting pregnant, who were pregnant, and they also excluded children as well. And this is true for the vast majority of clinical trials that we do in the medical arena. It's only once the vaccines are available that we're going to be able to gather such data. There's certainly ongoing trials looking at certain populations, and I'm sure there will be trials looking specifically at IBD patients. Although we certainly right now don't have the data in the IBD specific population, talking to the ID, my ID colleagues at Emory, there appears to be really no concern with giving the mRNA vaccine in patients who are potentially immunosuppressed. Again, we don't have the data, but when we take a look at what exactly these vaccines are, these are not live vaccines. They do not contain the virus. These are what are termed mRNA vaccines. So basically, it's a mode of delivering sort of the instruction set or the coding to human cells so that the cells themselves can start producing the spike protein to elicit an immune response. So given that they're not live vaccines, I'm not so much concerned about the safety data. Certainly when it comes to the efficacy data, that's something to take note of. The concern is if patients who are on immunosuppressives, or if they're on immunosuppressives, maybe they may not mount as much of an antibody response or a protective response if they were to get the vaccine. But this is true for all the vaccines that we recommend in patients with IBD, like the flu vaccine and the pneumonia vaccines. So certainly I do believe that, those vaccines in particular, the flu and pneumonia vaccines, even if patients are immunosuppressed, they still do afford some degree of protection. And I think the same is going to hold true for these mRNA vaccines. One important thing to know that these are just 2 of the vaccines that are going to be available by the end of the year. There's certainly over 50 vaccines that are currently being studied, and not all of them are going to be mRNA vaccines. I do know of one that does have a live vector, so probably that particular vaccine that's currently being studied, if it was to be approved, potentially I think I would be very cautious about recommending a live vaccine in my IBD patients, especially if they're immunosuppressed. But particularly with the Pfizer and the Moderna vaccine, those being mRNA vaccines and not containing live vaccines, I'm not as much concerned about the safety data. With that being said, currently, the demand is high for these vaccines, but the supply is low. So the first set of people who are going to get the vaccines are sort of your frontline healthcare workers, as well as those patients who live in assisted care living facilities or who work in assisted living care facilities. So when it starts coming to the general population, including the IBD population, I think it's going to be really important for patients to talk to their healthcare provider and review the data to determine if the vaccine is right for you. The other question that came up, will the vaccines be less effective for those on biologics, methotrexate and thiopurines? I think time will tell, data will tell us how effective these will be, particularly in that patient population.
Wonderful. Thank you so much. Does anybody else have any other questions related to the COVID-19 presentation, or just questions in general? You can type them into the chat box. I'll give you a moment to do that. I think we answered their questions. I think everyone presented so well. There were no questions. We got a thank you from Peter. Yes, thank you. All right, well, I will go ahead and close us out. I will send out a copy of the slides in a PDF format, and also a couple links to the website so you can see this recording once it's finished being converted. Thank you so much to Dr. Iskandar, Dr. Wolf, Dr. Dare for joining us this morning. They are volunteers and they put a lot of time and effort into these presentations, and everyone is very, very busy. So thank you so much for taking the time to do this. I greatly appreciate it. And again, I'd like to thank our program sponsors, Atlanta Gastroenterology Associates, Janssen, and UCB for funding this program. And thank you all again for attending. I hope you have a very good weekend. Stay warm if you're in Georgia, and happy holidays. Thank you so much, everyone.
Thank you, Mary, for an excellent organization of this meeting.
Thank you. Have a great day, guys. Bye.